Well, hey everybody, I'm Kevin. I'm a physician actually based at UCSF now, UCLA before, so it's truly spectacular to be back in SoCal. Really love it here. In terms of my background, so starting with that upper left image, I'm a radiologist by training, but specifically interventional radiology. So it's a little twist where, it's using imaging to do procedures, be it going into the blood vessels and taking pictures and finding a source of bleeding and, blocking that off, finding a tumor in the lung and placing a microwave probe in that tumor, using CT imaging, using that to eradicate the tumor. So just image-guided procedures in general. Trained in radiology, which is a field that's kind of obsessed with machine learning right now, and that's kind of in my DNA, but a little bit of a spin on it. That motivated me to start working with smart speakers, which you can see there on the lower left, the smart speakers with the very cute little surgical caps. Working in these sterile procedures, you quickly find that you're sterile and, whereas previously you could use a smartphone, you could use a computer, suddenly you're sterile and you really can't touch anything in your pockets. You can't, check your Instagram, you can't look something up, you can't, reference a medical text. So, in that kind of sterile operating room sort of environment, there's a lot of value in being able to quickly and sterilely access information. So you can imagine we're performing a procedure and we want to know, there's a little stenosis or, blockage in a blood vessel. We want to know, what sort of stents do we have access to that can treat this little blockage? In a perfect world, you'd be able to quickly look that up, but practically speaking, in terms of the workflow now, you ask the technologist that you're working with who's not sterile, sometimes they'll have to walk across the hospital and, he comes back 15 minutes later well, we have this stent and this stent and this stent, and, that workflow is just awful as you're kind of sitting there in your sterile procedure and doing nothing, waiting around. So if you can use these smart speakers to just sort of ask the room and get information about, the medical inventory or, a question about, I have this device and this sheath size going into the patient's vessel, does this device fit within that sheath? If you could just kind of ask the room and kind of immediately get that information, it'd be really convenient in the setting of procedures. And, there are a lot of other interesting value adds within healthcare of smart speaker technology. So I've started working on that. Then kind of building off of that, you can see the photo in the upper right, started using machine learning sort of robocalls in application to surgery and interventional radiology procedures. So, it's kind of taking that really cool Google duplex sort of technology where the machine learning agent would call a restaurant and make a reservation for you, but kind of coming up with a medical application of that technology. So the thing I built, when we have procedures now, we have a human agent that calls a patient prior to the procedure and goes over a sort of pre-procedure checklist. So, for example, telling the patient they can't eat the day of the procedure and, finding out if they're on blood thinners and kind of answering any questions they may have and so on. I built this sort of agent similar to the Google Duplex thing that can kind of go through that process with patients before the procedure, which is good because it's, it's cost effective. Human operators are fairly expensive and it's pretty simple, low-level work. In addition to the fact that it's very consistent, and sometimes the human operators forget to ask particular questions. So we'll occasionally have a patient show up to a really important procedure where we're, for example, going to treat their cancer or something, and they did not get the memo that they couldn't eat the morning of the procedure and it gets canceled, it gets delayed, theoretically their cancer might progress or something horrible like that. So this kind of makes our ability to reach out to patients and kind of go through this standard important pre-procedure process really standardized and effective, as well as inexpensive. Then also I built, applying chatbots to healthcare. It's a little thing from an article about it. Sort of based on the assumption that, as radiologists, much of our work is going through images, and maybe a particular study has, 5,000 images to go through, and you want to go through very systematically and kind of make the important diagnoses. But, the phone sort of ringing every 10 minutes typically, that's very distracting. Data clearly shows that those sort of lapses in concentration result in medical errors. In addition to the fact that many of the calls are regarding very low-level issues, for example, What level of kidney function does a patient need for a particular imaging study sort of thing, and that's just a really simple formula that's really amenable to being automated. So I made a chatbot that's sort of a first layer of communication for clinicians in the hospital in terms of interfacing with radiology. So for the really low-level stuff that's amenable to automation, they can just kind of text the chatbot, similar to texting a radiologist, and quickly get the information they need. Then for kind of more sophisticated issues, it also nicely plugs them in with a real human radiologist when appropriate. So that's good for the clinicians because they super rapidly get access to information, and good for radiologists because we can kind of focus more effectively on image interpretation work. So that's some of the stuff I'm working on. Really excited to be here, really excited about this discussion, and thanks for having me. Thank you.
Okay, well, I'm Kathy Jenkins, and I am a pediatric cardiologist from Boston Children's Hospital, old colleague of Anthony's. And I'm very glad to see that there are more pediatric cardiologists here in the room than radiologists. And I'm actually just super excited. I'm one of the people who is very grounded in the world of traditional medicine and of being drawn into this movement in a very natural way. In terms of my pediatric cardiology background, I was really the very first person in our field to use the largest databases at the time to try to make sense of outcomes in a pretty complex area. So I've been involved with data from way back. I also, for 12 years, built and ran the quality and safety program at Boston Children's Hospital. I was the chief safety and quality officer, and I'm now leading a center in advanced analytics with a goal to improve safety and quality, especially in pediatric care. So from that background, I've gotten drawn into a number of different, I guess in this rubric of AI, activities, and I've been asked to talk a little bit about the role of AI in quality improvement. So just in terms of some of the things I've been involved with, we had seeded a lot of work in natural language processing from a while back, and it's now coming to fruition. I also run a very large collaborative. It's actually a quality improvement collaborative in the developing world in low and middle income countries, and I'm involved with some work using AI to really triage high-risk pregnancies and high-risk newborns. And it's been very exciting to see those opportunities. And we also got involved in something called the National Patient Safety Partnership, where, to make a long story short, our institution took many, many terabytes over 4 years of all of our data from our warehouse, plus multiple other sources, and gave them to the MITRE Corporation to do various activities in quality and safety. And many of those activities are still going on and some of them I'm actually very excited about as they've moved forward. So the topic that I was asked to discuss from that perspective was how AI can impact QI. And so I really only have a couple of main points, because I want to talk about that a little bit, but also talk about something that's been a theme, especially yesterday, which is, especially for all of you not in healthcare, why are there a lot of barriers to really realizing the potential, and where are they, about how AI can impact QI. So the first way that AI can impact QA is pretty obvious. I would say the vast majority of the conference so far has been about this, which is just influencing quality, making quality of care better in different ways. We saw fantastic examples, many of them. The one yesterday from Mimosa about detecting tissue that was non-viable will make care better almost for sure. We saw another one with virtual reality in our field of placing stents properly, and many, many examples of that are around. One of the ground pinnings of quality improvement is actually quality measurement. It's a fairly incremental concept, but the way it's done now and today is really the old-fashioned way of participating in registries, getting benchmarks from other institutions. It's really a foundational concept, but there's a lot of new leading and incremental ideas. where AI or big data or analytics or real-time data can improve our quality measurement. I think that the shift that we're looking for, though, in quality improvement is really where the potential for AI is very, very great, and really is, as of right now, very much untapped. And one of these is moving towards this idea of surveillance. If you think from Sean Lane and cybersecurity and things like that, it's really about surveillance, almost a public health surveillance idea of really monitoring our care systems to enhance quality in more real time. And there's very little of that going on right now, but it's a really important shift. And with that shift comes another lens. And I actually personally really believe this is one of the most important ways that AI and big data and analytics is going to help us is to see the system as a whole. When you think of quality and quality of the system, it's really looking at the system of healthcare, that context in which healthcare is being delivered, and the ability of that system to deliver the outcome that you really want. And there's aspects of that system that are pretty far away from the doctor and the patient or the nurse at the patient, but are really very, very important. And our work with MITRE really started to show that system's perspective. We did analyses that showed how the acuity or the nurse staffing of the patient, a couple of beds down from the patient who had a med error, influenced the risk of that patient having a med error. And I think there's enormous potential there, and I haven't heard hardly any words about that system except maybe in the CMO section a little bit ago. But the real goal, the holy grail, is to bring all of that together and to actually be able to influence that system, to have action on that system in real time. And we have one of our first pilot projects that we're putting together in Boston, together with the MITRE Corporation, to try to do that in our cath lab, and maybe in a few years I'll be able to tell you about that. But I really only wanted to start with that and just make a couple of points about barriers and about where value comes from and what we have to show to bring AI into these conversations. The first one is in some of the space that we're in the quality care space and the quality measurement space, there's already systems out there that are doing this. And in order to bring your AI idea or tool or widget or algorithm in, you just have to show that it's better and of value according to whatever it costs and whatever burden brings it in order to do that. But our burden is much greater when we move into this idea of surveillance, when we move into this idea about really thinking about our system in its detail and in its complexity, and getting into that holy grail space of influencing it in real time. That's not just bringing AI into it in a meaningful way. That's really asking for an entire paradigm shift in how we deliver care in real time in our hospitals, and that is going to be much harder. And I think many of the sort of frustrating examples where people are asking why isn't AI just being adopted, not just in quality improvement, but in other parts of this conference, is because you're really asking for two things at once. And so that's my point that I'd just like to make.
I'm Gavin Bogle. I'm a patent attorney, and completely different than most of the talks this afternoon anyway. I wanted to thank Anthony for inviting me today. I was thinking about the different things I could talk about today, and I polled some people, and what I really thought I would say is maybe giving an idea. So I talked to some of the exhibitors, and one of them told me, I said, hey, did you try to file a patent on this technology? And they said, oh, we talked to a patent attorney, and he said it's not patentable. And I said to him, oh, good for your patent attorney. Instead of just taking your money and filing a patent, I did a search on Google, and there are probably tens of thousands of patent applications that have been filed, and many of them probably are not patentable in this space. And why is that? So what I put up here is actually the fundamental In red at the top is sort of the fundamental idea behind patent law. And this is from what a member of Congress had to say about the patent law after it was made back in 1952, that basically everything is patentable, subject matter that can be patented includes anything under the sun that is made by man. So or you have to think about that. Almost immediately it started to be defined what that meant. Laws of nature are not patentable. Natural phenomenon and abstract ideas are not patentable. Einstein's theory is not patentable. These are all cases that have looked at these things. They defined algorithms and mathematical formula as equivalent to natural phenomena. Data structures. Data structures is an interesting one because as with all things, in some things this could be patentable. So I would not say none of these things are patentable. But in the context of medicine, it's probably not patentable. But if you're using a data structure in order to improve a physical thing, a tangible object, it'll probably be, or it could be patentable. This is a pretty recent case, and I like the words so that people in this audience could take a look at it and think about it. Gathering and analyzing information of a specified content, then displaying the results, was found to not be patentable. Isolated DNA sequences are not patentable. In the case Mayo versus Prometheus, they found basically that diagnostics, the correlation of a diagnostic is not patentable, even if it is novel. Then we have the question at the bottom, which I really like, and I had this question on my slide, and then again, another exhibitor out front gave me their card, r-squared.ai, and I'm sorry for using you for an example, but their byline says, the AI that helps create AI. So if you go back to the top line, what is patentable is includes anything under the sun that's made by man. So an AI made by an AI is a little problematic. So I guess that's all I really wanted to say, although I was asked earlier today about non-disclosure agreements, fundamentals. We're talking about essentials. Everybody, and I presume everybody who works in inventions and doctors dealing with companies, healthcare providers, and banks and venture capitalists deal with non-disclosure agreements. And people sign non-disclosure agreements wantonly, and they just sign them and probably don't read them. And the question was asked, well, should I be doing that? And non-disclosure agreements, it doesn't matter if you're not successful. But if you invent something and you move forward and you've signed 100 non-disclosure agreements that you can't remember what you signed, you've got all kinds of confidential information from different people, there could be a problem. We read about these cases in the papers, people claiming somebody stole their invention or stole their idea. And this is where that stuff comes from. So you really need to be careful about what you sign. As a lawyer is going to say, you got to be careful about what you sign. Okay, so I'll say one thing. I didn't want to just give the problem. I wanted to actually offer a solution for people. And that is what you can patent. And you'll see I work at Systems Oncology. And what Systems Oncology does, as you heard earlier, they have a very, very big hypergraph database. And we've filed lots of patents over time. But what they try to do is file and acquire intellectual property on the tangible results that come out of the AI and out of their databases and out of the interaction of databases with people. So always think about the tangible result. The other thing I would urge you to do, which is a little bit different than what I used to tell clients to do, but certainly in this space, before there's a trade-off when you get a patent. You reveal everything about your invention in return for a limited exclusivity period. The problem is you have to think about that. You reveal everything about your invention. And you really have to ask yourself, do you want to do that? What I would argue with respect to this audience. Before you go and file a patent application, you really should ask your patent attorney to do a full patentability opinion on it for you to decide whether or not you want to disclose your crown jewels to the public, with the possibility that you might not be able to get a patent down the road. Thank you.
Thanks, Kevin.
My name's Sina. I work with iMerit. In the medical AI space, I think as clinicians, a lot of times are non-technical people. When we look at it, it can kind of seem like magic. And so in the most basic sense, I think when you peel back the curtain a little bit, you see that artificial intelligence is actually a lot of human intelligence with some pretty sophisticated and amazing pattern recognition models to create statistically predictive models, right? And so that human intelligence, where that comes from, is actually one of the big obstacles in medical AI, and is an obstacle in a lot of different high domain expertise fields. So if you look at, say, autonomous driving, right? We're estimating that you need about 100,000 to 1 million instances for every class to build a pretty robust model. So that's 100,000 pedestrians, cars, bicycles, everything that you're going to see. Now, in the medical space, it's not an apples-to-apples comparison, but if you need some fraction of that, but only a pathologist or a radiologist or a cardiologist can do your segmentation, can do your annotation, suddenly you've got a very expensive problem once you multiply it by every different type of abnormality. So this is kind of a mock-up of that, and the reason that is because that level of expertise starts very broad, right? Because patients don't come in, they don't tell us what's wrong with them. We have to figure it out. We start with an unknown, and then we narrow it over time. So what I've been involved with over the last year is actually taking that need and connecting it with a global workforce looking for opportunities. And so we take people who are disadvantaged and then develop a curriculum that is broad in the sense that people understand what they're doing. So that's sort of the foundation that transfers the learning from sort of basic memorization and pattern recognition into a deeper understanding. And then we teach very specific but very complex tasks that we can do in much larger scales than you could potentially do otherwise. So that's the approach that we're taking. We are, at this point, more successful than I thought we'd be. So it's something that, you would think you could do with maybe an X-ray. We're doing, multiplanar navigation in 3D imaging and able to segment different parts of the neurovasculature. We're able to identify different parts of, or different cell types within a bone marrow aspirate. So it's pretty complex work. And in that sense, we are helping take medical AI from like the R&D space into commercialization. Because the human intelligence that we really need for medical AI to work, I think, is equally distributed around the world, but the opportunity to it is not. Thanks.
Thank you. I don't really know how many times people walk into rooms without washing their hands. Mm-hmm. It takes probably a typical safety report 10, 15, 20 minutes to write, so therefore nobody writes the safety reports. How do you see that we can possibly get past that sort of data conundrum, that unknown, and perhaps maybe use artificial intelligence to discover some of those things and then leverage that to improve quality?
Yeah, so I sort of think of the Johari window and the known unknowns and what you don't know. I think it's a really interesting question. It's a difficult question. I heard part of the last session, and we were talking about domain expertise. I think in the end, medical AI, the most important thing in terms of asking the right questions comes from clinicians, comes from domain expertise. And then second to that is the input data. And probably third, even though this is what I think if you go to most AI conferences, people are talking about different algorithms, and that's probably third to the first two questions. And those obstacles are considerable, not just in how you form ground truth data, but data siloing and HIPAA compliance, all sorts of problems that we have with medical data.
Kathy?
Yeah, I guess I would just say, just to state the obvious, the traditional answer that a chief safety officer should give is, well, we need to change our culture, and then everyone will tell us all the vulnerabilities of our system and report all of the adverse events, right? But the more latent they are, and the less and less likely that's really to be true. One of the NLP uses that some of the people who work with me have been to actually explore some of the contextual factors of what is and isn't in the record to kind of identify even adverse events or complications that were kind of under the radar screen. So given that there's some signal in the record, maybe we can find them with AI-type techniques. I think, I could imagine these patterns of behavior that might show people's, vulnerabilities in the care they deliver could be sort of another layer to that. But at the end of the day, we have enough work to do to improve healthcare with the things we already know aren't working well. So
Sure.
I'll leave it at that.
With regards to hand washing, you just know in the future there's going to be like machine vision, like watching us in the bathroom, like verifying the hands were washed, then it's going to like unlock the door and you can leave or something. It's kind of a very Big Brother situation.
Actually, that was
it's
kind
going to happen.
of
You just
where
wait.
I was getting at. I remember watching a video of a computer vision AI platform that detected. It was designed for retail establishments to detect shoplifters. And it was able to very reliably do this so that the people who are monitoring these security monitors, it's mind-numbing work. You're not going to pay attention to all that. But if it like blinks up something that says that person is doing something suspicious, so I'm thinking that perhaps something like this could then record that, something like that, and actually send in a passive safety event report. And that's the sort of thing that I think that we should be trying to get at, not necessarily saying that some of these secondary indicators that you talked about are not useful, but to get really truly where we want to be, we want to get to some sort of primary reporting mechanism.
Yeah, I guess, though, that rather than just finding the bad actors in the system, I think one of the things that I was alluding to was finding the vulnerabilities in the system that we're just not even aware of. That on one day in our ward, we have fewer nurses with a lot of experience. And that makes our ability to recover from a complication that happens in our cath lab greater. Sure. Because more and more people just don't run in, or that there's capacity challenges. And so those kind of unknowns, where they're there, they've always been there. And they happen randomly or in a probabilistic way from time to time, but we're not aware of them. But we can help with that is what I find very interesting.
Sure.
I saw an interesting deck for this like stealth machine learning company applying machine vision to surgical procedures where they look at the laparoscopy video data during surgery and they both identify like errors made by the surgeons and create like a surgical report card sort of thing, which I think is probably a little before its time, but kind of an interesting QI application, and also with some kind of Big Brother undertones that are interesting.
I personally know of one surgical documentation vendor who is trying to target, the eventual goal is to have the surgeons wear sort of a headset, have a boom microphone. It records the surgery. And the plus for the surgeon is that, much as Rush talked about earlier, and some of their ambient documentation that they're trying to develop in conjunction with Nuance, that the plus for the surgeon would be that when they leave surgery, their surgical note is already written. But in terms of safety, you could also be collecting all sorts of other data then to try to then be able to record that data, maybe cross-index that, and join that with other clinical outcomes and say, this particular maneuver when you're in this sort of surgery is probably not a good thing to do. Let's try to tweak what we're doing, or using a particular type of instrument may not be the right thing to do. Plus, I think if we fully leverage that, we could probably also improve some of our surgical efficiencies, because a pretty significant problem is that we have surgical trays that are often curated and created by the surgeons that were created maybe 10 years ago, and they regularly only use half of the instruments. So now you have this entire stock of instruments that you have in stock and sterilizing, but you never use. So that's an operational inefficiency that I think we can probably leverage as well.
We do have a surgeon here. How do you think surgeons would feel about these applications of AI?
I mean, if you didn't use something for 10 years, but it was the thing that got you out of some, terrible mess, and when you need it, it's not there, I mean, you're going to blow your top. So, I think that there's a lot of gains to be done in surgery, but like everything in medicine, there's an art to it. There's a flow that you need to get into to do it successfully. And so, again, coming back to domain expertise is really, I think, in our interest to really be driving this, because when solutions are introduced from the outside, if they break up your workflow and get you out of your rhythm, they're going to be rejected.
And I would guess that if you could make a part of that system, not just surveillance for some sloppy surgery, but some ability that you could give a surgeon a heads-up warning of some latent vulnerability of what they just did, that's when the surgeons would really embrace it.
Sure.
So the company I saw, the value they were offering the surgeons, at least initially, was creating like a labeled, curated database of particular steps within a surgery and particular complications and different things to kind of go back and review, so you can see like, okay, for this one really nuanced part of the surgery here, like, 50 times someone did it, and here are the things that went wrong and right and so on. So some sort of database they can go through and learn from is sort of an initial bit of value.
Gavin, I think it was yesterday, today you talked a bit about patents, and really what it comes down to is that you want to create an infrastructure, a legal infrastructure, that incentivizes people to innovate so that they get rewards, economic and otherwise, and that they can own those sorts of innovations. And you kind of said here that maybe that's not as easy as people may think that it is, but I think it was yesterday that someone mentioned maybe not on the output side, but on the input side, creating exclusive rights and use to source data. And then is that a viable way to kind of work that system and create those sorts of incentives?
Sure. I mean, there's actually, sorry. There's actually lots of, one of the problems with the traditional system is it wasn't designed for really AI. At the time that these cases have been developing over the last 70 years, the case laws, as we heard this morning, the case law and judges always follow behind. And where we sit today very quickly in the world of AI and medicine, everything moves very quickly, and it's very difficult for law to keep up. But I really do think right now, you need to look at alternative ways of protecting your inventions and your data. I mean, part of the reason for the patent law was that you disclose everything, and in return you get a limited monopoly. And in the old days, 20 years seemed like a pretty reasonable, or 17 years, it seemed like a pretty reasonable. Today, I mean, I can't even imagine today's AI invention even being useful in 20 years. But
So is there any talk about having something like that, but updating it and reducing the time frame?
well, the interesting thing in the pharmaceutical world, and I've said this to many people recently, the data exclusivity you get through the FDA and through their approval of your products in many countries, including the US, is actually more valuable than the patent that you might get, because it comes from approval, and your patents burn very quickly. So the idea of protecting your data is actually already a part of our system. So your suggestion, I think that's actually a very good suggestion. The issue, there's so many issues around the data involved in medicine and the intellectual property of it, and how to incentivize people to, right down to a patient, how to incentivize a patient to give up, let you use his data. All of those things, and then how do you incentivize entrepreneurs to use that data and develop something new? Actually, I guess what I would say, being a patent attorney, probably patents are a very poor way of actually doing that in this kind of space, and looking at how we share the data and who can gain value from the data, I think is actually what we need. We need some innovation in the intellectual property space that is difficult.
Do we have time for questions? I'm sorry? Okay, let's open it up to questions. Anybody?
Question for Gavin. No.
This is my boss.
So you explained what we can't do, but you haven't explained what we can do. Talk to us about alternatives, trade secrets. What avenues do we have to protect
Sure,
inventions?
and that's what I was hoping to get to a little more. I think right now, if you go around and you walk down the aisle out front and you talk to AI vendors and whatnot, the algorithm, they're never going to tell you what their algorithm is. The reality is that's the secret sauce, and even if they could get a patent on it, which I'm not saying they can't, there are some ways, there are some possible ways of doing that, but the real question is, do they want to? And should they want to? Those algorithms evolve over time, and they get better and better and better. So I think what you really need to do, it depends on the company, but Systems Oncology, as an example, has, as I mentioned, has a tangible output from their graph databases. And those tangible outputs are patentable. The novel drugs that they come up with are patentable. If you look at, I mentioned data structures. Data structures, when used by, for example, Google or Intel to improve their computer, where they produce a tangible result, would certainly be patentable. So I think concentrating on the tangible output in whatever form it takes, is a good approach. The other, I think, keeping it secret is actually, as Dr. Musa suggested, keeping it as a trade secret is probably a pretty good idea too. And for a patent attorney to say that tells you that things have really, there's a lot of flux in patent law these days. I wouldn't have told, it would have been almost unheard of a few years ago for a patent attorney to say, keep it a trade secret.
Okay, I've been given the circle the wagon sign. Thank you, everybody.